minute or two to add everybody into the room, so please sit tight and we'll get started in just a moment. Thank you. Morning, everyone. We're giving Zoom a minute or so to add everybody into the room so we can get started, since we have a lot of people registered. So please just sit tight. We'll get started in just a minute. Thank you. Morning, everyone. We're still giving Zoom a few moments to add everybody into the room, so please sit tight and we'll start in just a moment. Thank you. Okay, we will go ahead and get started, and any latecomers can join as they arrive. Thank you, everyone, for joining us. Welcome to the latest Duke media briefing on the COVID-19 pandemic. I'm 𝐿𝐴𝐿𝐼𝐻𝐿𝐼PS with Duke Communications. COVID cases are rising again in North Carolina and elsewhere, fueled by reinfections and particularly contagious variants. But with more people testing at home, the full impact of the current increase is difficult to measure. We have two Duke physicians with us today to discuss what hospitals are currently experiencing and the outlook for the summer and beyond. With us this morning is Dr. Adia Ross. She is an assistant professor of medicine at Duke and chief medical officer at Duke Regional Hospital in Durham, where she works with medical staff and operational departments and oversees quality and clinical programs. Also joining us is Dr. Cameron Wolfe. He is an infectious disease specialist at Duke Health and an associate professor at the School of Medicine, where he studies infectious diseases and biological and emergency preparedness for hospital systems. Good morning to you both. Dr. Ross, we'll start with you. We've seen that cases are up across this region. What kind of hospitalizations are you seeing with the latest uptick in cases in the area?
Yeah, actually, as a health system, our hospitalizations, we have about 90 people hospitalized right now. Our positivity rate of all the tests that we're doing are about 18%. But when we look and see where we were probably about a year ago, we're only about 10 to 15 cases higher than what we were last year as far as hospitalizations. And actually, there's fewer patients requiring ICU care, which is encouraging. And I think that kind of follows some of our national trends that are showing, even though the cases are up, a lot of the hospitalizations are not as high as they have been as a percentage of the cases.
Absolutely, thank you. There's a lot more we'll dig into there, but Dr. Wolfe, I'll move over to you slightly. Dr. Ross has just said that the hospitalizations are not much higher than last year, but it seems like we're seeing a lot more cases than we were this time last year. Are you expecting that the holiday and the start of the summer season will see that increase continue? What do you think we can expect from the next month or two?
Yeah, it's a good question, Greg, and thanks for the invitation to be here. I mean, I think if you look back over the last couple of years, unfortunately, the lesson from the two summer holidays in 2020 and 2021 was that we did see an uptick in cases. Although it didn't necessarily match perfectly to when public holidays occurred. So in actual fact, Memorial Day weekends had not been large spikes for us last year, for example. That spike actually came much later in sort of July and August as a different variant appeared. So it's a little bit harder to predict this year, I think, is the right answer to that. And we know, as you got to and alluded to in the introduction, that there are more infectious variants here at the moment. There's no hint on the horizon globally that there's a sort of markedly more infectious variant appearing, or one that's likely to sort of evade immunity. That would throw any prediction out the window to some extent. But look, at the end of the day, what happens on public holidays is that we all, with much relief, honestly, after the last 2 years, prefer to hang out with friends and to be out and about and socializing and doing more activities. And that does lead to some degree of mingling for sure. It's really hard to pinpoint that down to specific holidays, though. So generally, our experience has been that the summer months have resulted in uptrends by the end of the summer, although predicting which week that would be is not straightforward.
Sure, absolutely. Thank you both for those introductory remarks. We're going to open it up to questions now. Thanks to everyone who submitted questions in advance, and we'll start with those. You can also pose questions via the Q&A window at any time. If you'd like to ask a question in person, raise your hand in Zoom and we will unmute you when your turn comes around. And if you're calling in by phone, you can raise your hand by pressing *9. Dr. Ross, I'll come back to you. We've had a number of questions about who actually is getting very sick from COVID right now. So with the hospitalizations that you're seeing, are there particular risk factors that you're seeing, whether it's age or being unvaccinated? What's the kind of composition of people who are getting severely ill and dying from COVID at this point in time?
I still think though most people that are getting really ill are unvaccinated, as well as those that may have some predisposition as far as having multiple illnesses. Again, I think even if people are coming in the hospital ill, they're definitely not requiring the same level of intensity of resources. But I still think if you're unvaccinated, your risk of getting very sick remains the same. I think what we're seeing, and of course, as Dr. Wolf said, it's hard to kind of fully understand all the factors, but just, all of that, the hospitalizations and those that are at risk is being modulated by the high rate of vaccination within our country right now, which is a positive thing. But I still think if you're unvaccinated, you're still at high risk for getting severe disease.
Absolutely, thank you. Dr. Wolf, coming back to you on the topic of vaccination, as Dr. Ross mentioned, we've reached a pretty high level of vaccination in this country, but have we got at a population level about as much protection from vaccination that we're going to get, or is there the potential for the vaccine to penetrate further into the population, or have we kind of concluded at this point if people aren't getting vaccinated by now, then for whatever reason they've made their decision?
Well, there's a health element to that question, and then there's a sort of a sociology element to that question. So the health element is no, we've not reached an adequate amount of immunity in the population. There are plenty of countries who've done far better than us. I was fortunate, for example, to take a family trip back to Australia where the rate's 95% vaccine uptake, and we're sort of, in some sense, comparatively languishing in the 60s and 70s. So is that better than where we were last year? Of course it is. Can we do better? Yes. And I think that there's two issues there. One is the overall rate of vaccine with uptake in the community. We still have a large group of people who've been very reluctant or resistant to take vaccine. I think the other thing that's relevant there is that we now know more data about vaccine immunity waning over time, and that is why we've been pushing on some of these presentations and nationally to talk about boosting. We did not know that a year or two ago when vaccines were first available as to what their durability would be in the face of new variants. We now understand that sort of resilience of vaccination is not as good as we would have liked it to be. It's not a tetanus vaccine that lasts 10 years. So we have been encouraging people who either lose their immunity more rapidly, so that's immunosuppressed people or folks who are older, for example, than 50, or people who are at higher risk themselves, so again, immunosuppressed people in particular, that even if they've had their first vaccine, sort of propping up that level of immunity can be very helpful. The second part of that question, though, is not a medical part. That's a sort of the more actually, frankly, the more challenging part, which is the sort of social element to that. And there's a political element to that too, to say, are we willing or able to motivate people to get that extra level of protection? That's been a real challenge. That will continue to be a challenge moving forward, is to let people receive a message of why vaccination is important and helpful for them in a way that they can receive and understand and feel comfortable with. That's an ongoing challenge, and I think something we need to keep working at, frankly, not just for COVID, but for all vaccine-related illnesses.
Absolutely, thank you. Dr. Ross, coming back to you, we've had a number of questions about the prevalence of the BA2 variant and other variants. In the case of the hospitalization cases that you've seen, to what extent are you able to test for those variants, and what kind of levels are you seeing, at least in this community, in regards to prevalence of the BA2 variant in particular?
I think the predominant, but I would love to get Dr. Wolf to kind of also weigh in on this, but I think the predominant right now that we've seen is BA2, but Cam may be able to talk a little bit more about the specifics in our hospital as far as the lab tests.
Yeah, we've, so you're right, Nadia, we've mainly seen BA2, and it's been mainly BA2 now for quite some weeks or months in actual fact. Greg, in answer to your question, the testing that is required to genetically sequence virus to determine which subvariant of Omicron it is takes time. You don't ever find that out in the real time for the patient sitting in front of you, or at least we can't. And so we usually know this week what was prevalent in the hospital or the community last week. And what that has shown is that it's been overwhelmingly, almost exclusively Omicron, let me start with that. And that as we move through February and March into April, particularly BA2 and many of its subvariants replaced completely BA1 for us. That's a national trend. That's not unique to North Carolina. But what you see is the more virus exists, the more capacity for little subvariant creation also occurs. And so, in fact, what we're seeing here is we're now already seeing the emergence of some cases of BA4, BA5, and some other sort of cross-fused variants, if you will, that are all present in very small numbers. That's not surprising. That's what we expect. What you find is that over time, the viruses that exist in the predominant amount tend to be the ones that are more fit. So BA2 has tended to be a little more fit than BA1, and then more specifically, a very particular subtype of BA2 by the name of BA2.1.2, to be really specific, is a little subvariant of that, which seems to be uniquely fit at the moment and capable of transmitting. They're fit in that they're easy to spread. They're not necessarily more evasive to our immune system or to our vaccination, which is really valuable, although we're watching BA4 and 5 closely because there's been some hints in South Africa that that's been an early trend. I hope that answers that question.
Yes, absolutely. Moving on from that, and I'd like to get both of your takes on this. We've had a number of questions about reinfection. People are curious to know, like, what do we know and what we don't know, or what don't we know about the likelihood of reinfection if you've had COVID before, or if you've been vaccinated and then had COVID, and the likelihood that a reinfection will be more or less serious, than the first time that we get infected, and whether it changes the the risk of long COVID, which I guess is very much like three questions in one. The likelihood of reinfection, the likelihood of severity of reinfection, and the likelihood of long COVID as a result of reinfection versus a first infection. So if either of you want to kind of talk a little bit about what you've seen as regards reinfection rates and whether reinfection has an effect on severity, then we're interested in all of that, I guess is what I'm saying.
Adia, I'm happy if you want to go first, or if you
can start.
Okay. Yeah, look, Greg, it's a really important question. I think the first thing to say is people need to recognize that reinfections occur. Let's just put that plain and simple. That is true of older style coronaviruses that we saw more prevalently in kids. We knew for a long time that the immunity generated by many different coronaviruses is not long lasting. You can get, I'm trying to think of a good example. You get a measles vaccine or a case of measles, your immunity lasts for a hell of a long time. That's not the case with coronaviruses. So reinfections are not surprising. What's been a little disappointing, I think, to me at least, is that we're starting to see reinfections of people who had Omicron getting Omicron again. And whereas previously, it was really limited to folks who were exposed to a totally different variant. So, for example, we knew that Delta gave you very little protection against Omicron. It seems that the immunity generated from Omicron is also not quite as strong as maybe we would have hoped. And there have been some cases for sure we're picking up in our sequencing lab where folks who presented and tested positive in December or January in the early phases of Omicron are testing positive again. It's a much harder job, and I'm not sure that I have the perfect answer to say, is that because of a subtle drift in the variant subspecies, or is that because of your immunity starting to wane over those months, or some combination, frankly, of both? It's probably the latter. What is true is whether your prior exposure to Omicron and your prior exposure to spike protein is through a vaccine or through prior infection, it does seem to be reassuringly true that subsequent infections are less severe. So I personally have not seen anyone who's come back with a second infection outside of our really immunosuppressed patients who just frankly don't remember the last time immunologically they're infected, who come back in and get sick enough to be hospitalized. That is incredibly reassuring. This would be a very different conversation if that were not the case. So I do think the level of protection that you retain from prior infections or from vaccines has led to less severity. That's now quite clearly shown. There is some data in the UK now that they've published that looks at whether or not vaccines, and I suspect, although I don't think it's proven, by extrapolation, reinfection, prevent you from getting long COVID to the same extent. And that seems to be the case, that a vaccinated individual who retains some level of immunity seems to, on average in their trials, be about 50% less likely to end up with long COVID. And the hypothesis that goes along with that is that that has been sort of, if your body knows how to respond and remembers a little bit about how to respond, it's less likely to have the sort of deranged response that we saw in 2020, where people ended up with these very hyperinflammatory type immune responses. So again, that's reassuring. I would not say that that's been exclusive. They certainly saw plenty of people who still came down with long symptoms that remained present for sort of weeks after their virus had cleared. So it's not an excuse to be flippant about this. Let me end by saying that.
Yeah, I think that that's a really some important points. The other thing is, I still think the vaccine, when we think about all the different things that it's supposed to be doing, one of which is obviously to hopefully help us not infect others. But I think, preventing severe illness, hospitalization, death, I mean, it seems like, it has really held up in that way, which is very, very important when we think about those that are most vulnerable, including our children and elderly and those that are immunocompromised. And so just don't want to lose sight of that as well, because I do think that is important. And for, anecdotally, the patients I've taken care of and the family members, as Cam has said, they definitely seem like they've gotten it twice. It's not as severe, which is very reassuring, and we hope it will continue that way. But I do think it's really still important to think about the purpose of the vaccine and how important it is for not overloading our system and preventing further deaths.
Sure, absolutely. Thanks to both of you. Dr. Ross, I'll stay with you, and Dr. Wall, feel free to weigh in too. One of the things people are wondering about is, currently with boosters and additional boosters being recommended for, older patients, do you expect that we should see more widespread boosters being recommended, like follow-up boosters for the general population? Do you have any sense as to how likely that is, or whether it would be effective?
That's a good question. I'm not as up to date in that community about whether the boosters with the criteria for others, but I would suspect that it's really going to be based on, the risk of severe infection and how things hold up. But Cam, I know you're working those circles, and if there's anything else you can add specifically that, beyond the populations of greater than 50, and then, obviously those from 5 to 11 are now eligible for their first booster.
Yeah, Greg, do you mind just repeating the question again? Sorry, mate.
Sure, absolutely. We had questions regarding what do you think the likelihood is that additional boosters will be recommended for the under 50s, essentially, is what the question amounts to, whether they would be effective.
Yeah, for under 50s in particular. So, the US took a very deliberate path, having watched data emerge from Israel and parts of Europe, frankly, where different countries had taken variable approaches in terms of who they sort of second boosted, if you will. And, that led us to take a decision to choose 50 as a, somewhat arbitrary time point where we think immunity waning was important to reboost. It's not just the immunity that's the issue there, it's what your immunity is against. And so, if you think back to November and December, when we saw the emergence of Omicron, we took a collective decision to take a much more aggressive approach to boosting, because we saw something coming towards us that was going to be much more difficult to contain, and certainly proved to be the case. So part of this is a question of saying, if we see another wave emerge, either within the United States or somewhere else, that we feel is going to need a community-wide prop up in vaccine level, then that would be a signal to vaccine manufacturers and the ACIP within CDC to say, look, hey, we probably really need everyone to be a little more propped up. That's certainly an effective strategy. At the moment, it's reassuring, as we sort of talked about, that the magnitude of severity for most folks who are younger than 50 and otherwise healthy has not been so severe. And there are at least theoretical arguments where over-vaccinating can cause some challenges to the sort of the length of the memory that you create. The other part of it as to why I think we're not yet ready to sort of sign up for everyone under the age of 50 to get vaccinated is that, as you probably know, there are companies who are working steadily on trying to tweak, if you will, the vaccine ingredients to specifically target variants. So a couple of weeks ago, it's now that Moderna had released their preliminary information looking at variant boosters, and we expect that they'll have more information about an Omicron specific variant combined with the original wild type that's anticipated to be sort of ready for prime time in September, rough estimates. So I think seeing that data in front of us, seeing how busy COVID is at that point, and whether we've had any other emergence of variants will help define the sort of the lower risk population as to when they need a booster. I think it would be likely overall that that will continue to be the case. How frequently that is required, I don't yet know. I'd love to be able to think that we could fold it into other vaccines to make it simply more logistically easier for everyone to get boosted, but the timing of that is not clear to me yet.
Sure, absolutely. Thank you both. Thanks everyone for all of the questions. Keep them coming and we will get through as many of them as we can in the time that we have. Dr. Ross, I'd like to come back to you. We've had a number of questions here about people that have had COVID and are trying to figure out on an individual basis when it's safe to kind of re-emerge. Obviously, the CDC has its recommendations of isolating for 5 days and wearing a mask for an additional 5 days. But can you talk to people about what kind of factors individuals should be looking at when they're trying to make a decision about kind of going back out into the world? Should they be looking at whether they're still testing positive, for example, still symptomatic, still feverish? What are the different things people should weigh in those individual situations?
Yes, I would say, it's important to look at the CDC guidelines because those are really kind of the standard. But again, if you've had COVID and you're still symptomatic, you really need to make sure that you're still remaining quarantining. But in general, if you, as long as it's been more than 5 days and you're asymptomatic, meaning you don't have a fever and you haven't, you're not taking like medicines to decrease or your temperature, and you know that you don't have a fever and your symptoms are better, then you can leave your quarantine and wear a mask for the duration for a total of 10 days, a high quality mask during that time. I think what people need to really, consider is others and, thinking about even if you're in quarantine, if there are others that are very vulnerable that aren't infected, really trying to make sure that you have really good, you're wearing a mask and you're doing that consistently. During that total 10-day period. And if you have concerns about your symptoms not resolving or you're still fevering, are the things you really need to get in contact with your healthcare provider to make sure something else isn't going on or you're not getting worse, as well to assess, whether it's appropriate for you to come off quarantine. But I think following the CDC guidelines is probably the best bet. And I think it's important for people, even in the midst of, testing and whether people, we have in-home tests and other ways to make sure that if you are exposed, that you really know what your status is to protect those that are vulnerable and or aren't eligible to be vaccinated.
Sure, absolutely. Thank you. And as a follow-up to that, before we move on, in a case where somebody has, say, followed the guidelines, maybe they're 12 to 15 days out, they're no longer symptomatic, but they're still testing positive at home. Is that something where people should use that as an indicator to maybe continue to quarantine or continue to wear a mask? Or is it a case that we see where the virus is still present in the body even after people are no longer contagious?
Yeah, I will also defer to Cam to kind of answer that as well. But I think, I think you can still test positive for several days after you've been infected, even if you're past the quarantine period. So, but I do think that I would like to get Cam to weigh in on the latest guidelines with that piece.
Yeah, so the number one, there's an interesting question in the comments to this about, are we seeing this more commonly? I think we're identifying it more commonly because we have a much wider access to testing and people have an easier sort of follow through of checking themselves. I'm not sure that it's necessarily occurring more frequently. We're seeing it more common. So, I completely agree with what Adia had said, that the guideline that the CDC have in place about sort of 5 days plus 5 more in a mask is based on really solid information about infectivity, not just do you test positive, because we've seen for 2.5 years that people can continue to shed virus for, in fact, some weeks often is the case. And that doesn't mean anything in terms of their infectivity. It just says you've got dead virus in your nostrils. So in general, when you look at, can I culture virus? Can I find it in an amount that's actually transmissible between people? The 10-day outer limit that the CDC said is really a very conservative value. In fact, most people are probably not infectious well before that. There's a couple of situations where to build on Adia's comments about who's in the house that I think are really relevant. Like, if you're around someone who's immune suppressed, or at high risk, if you're a healthcare worker, I think this is a different situation. You know, I want to be more conservative with people coming into my transplant service, for example. If you're someone who yourself is immunosuppressed, we know those individuals can potentially shed for longer. And so there's different guidance for those folk. And I think the other group that's sort of come to attention recently is people who've had some of the antivirals, so particularly Paxlovid. There's this very small group of people who sort of have their treatment, feel better, the antiviral stops and their symptoms come back. And in fact, they can sometimes go from rapid test positive to negative when they feel better and then positive again. And that's a sort of an emerging awareness, I guess, of the potential for small amounts of virus, we assume, to have evaded the antiviral, evaded clearance, and to reappear. And so in fact, the guidance in that unique situation is to say, we presume you're reinfectious again if your symptoms have reemerged and you test positive again. So those people, in fact, have an extended isolation period. That's rare. Again, I think that's probably been highlighted more recently because there is such an availability of drug, there is such an availability of testing, and people want to test a lot and monitor their sort of antigen values, if you will. It's not that the virus has changed in that regard. So if that's a little confusing, it is for us too. I'll be totally honest. But that's where I think falling back on what the CDC have put out as intentionally relatively conservative isolation measures is actually really important.
Sure, absolutely. Thanks to you both. Dr. Ross, coming back to you, as we know, in North Carolina, cases are up, and they're up in cities across the country, but most mask mandates are gone and the decisions are being left up to individuals. Here in North Carolina or in central North Carolina and other places where cases are higher, what kind of day-to-day things would you recommend? You know, in a community like the Triangle where cases are up slightly, for example, do you think it just makes sense for people in general to wear masks at the grocery store, this kind of thing? What do you think are some of the general principles that people should follow when they know cases are slightly higher?
Yeah, I mean, I think this is a great question. I think it's something that all of us are grappling with. I think, you know, to be honest, we're all, it's been a long 2.5 years. And so people want to get out and do those things. And those are important for mental health and just continue to build community. So those things are important that I think many of us we're going to do. So I think having common sense kind of guidelines and really think about your individual risks, the risk of environments that may be more high risk, and then those around you, who are you around and what is your risk of spreading things to them? And so, you know, I think it really is, you know, we've gotten to a point now with mask mandates, at least at this current state, and partially probably because our hospitalizations are not as high, because part of the reason that we kind of had the mandates that we have is that we were trying to make sure our resources weren't taxed in the community. And so we're not quite at that point. And so I think for many local governments, their current guidelines are taking that into account. So I would say, you know, thinking about your individual risk, you know, when I'm going into a grocery store right now, I still am wearing a mask. In areas where there's poor ventilation, I'm going to be with a lot of people and can't social distance indoors, I'm still wearing a mask. I think, you know, thinking about other settings, churches, schools, those other things, I think, again, thinking about your individual risk and your vaccination status to decide, you know, what makes sense. But I think, again, thinking about when there are areas of high transmission, you know, what if you're going to go visit, you know, we all want to see our family, we all want to see our friends. If we're all going to be indoors and we're not in the same household, it probably does make sense for us to be wearing masks during this current time. You know, and definitely if your child isn't vaccinated, I think that's still, and you're going to be with another family, I think it still makes sense.
Thank you. Cam, anything in particular that you'd like to add to that in terms of particular recommendations for people in places where cases are elevated?
No, I like the individualized decision making that Adia sort of highlighted there, because I think even sort of thinking a little selfishly, frankly, about the way that people can choose to behave. If you know, for example, you've got travel coming up, like it makes sense not to derail your own travel plans by getting sick in the lead up to that. You know, we know timelines now really well, so people can sort of be more conservative in their mitigation efforts in the week leading up to travel plans. They can be more cautious on airplanes still. You know, everyone's taken masks off on planes, and the airlines will have us believe that they are a safe mode of transport. But at the end of the day, if you're sitting just right beside someone who's coughing for 2 hours on a plane, you have some risk. So, but that can be an individualized decision to say, look, I don't want to ruin a family holiday by getting sick on a trip. And that's, I think at the moment, there's good rationale for people to make those sort of individualized decisions in a way that's helpful for them. Particularly that's relevant for international travel, where the rules are still different in every different country. And folks don't want to get sort of into the situation of testing positive overseas and then having sort of returning to the US travel sort of interrupted too and become complicated for other reasons. So you can make really individualized decisions.
Sure, absolutely. Thank you to both of you. Again, you can post questions via the Q&A window. We have several in there. We're going to barrel through as many of them as we can before we run out of time. Dr. Ross, I wanted to come back to you. You mentioned how it's been a long 2.5 years, and that's certainly been the case in hospitals as you guys are having to plan for more potential surgeries. Can you talk a little bit, and I'd like to hear from Dr. Wolf on this too, what morale is like currently amongst healthcare workers and what you've been able to do to prepare for potential surgeries and to keep morale up against among workers who are, struggling and treating people who are often unvaccinated?
I think our morale actually right now is pretty good. I mean, our cases are down. I think we have learned a lot over the last 2.5 years and have a pretty good sense of how to take care of patients. We really are focusing on, I'd say our protocols are still the protocols that we have, but in many spaces, although we still have the capacity to have COVID units, we also are continuing to see COVID patients kind of spread across our platforms and different floors in a way that we do with flu and other things. And if they require if they require a large amount of care, more than the average COVID patient, then we're segmenting them. But I think actually morale is pretty good. I think we're all concerned and have honestly a little bit of PTSD from these past surges. And so every single time you have one, everybody kind of has to take a deep breath and remind ourselves, yes, we got this, we've done this time and time again, and just hoping that the community is going to be well. And then some of our workers are getting sick, but again, we know how to handle that. And with the CDC guidelines, we've still been able to really decrease the chances of transmission between healthcare workers. So I think overall we're doing good, but you're always prepared and trying to get yourself mentally prepared for what we could see next. But I think the main issues that healthcare is facing continue to be our staffing shortages and just the question of, as we go into each surge and hoping that our, fingers crossed, our vaccine is going to help us continue to have decrease our incidence of severe disease and hospitalizations, but just trying to make sure that we can do what we can with the staff that we have.
Sure, thank you. And Dr. Wolf, as we get your thoughts on that, we've had questions about whether you're actually anticipating a further surge in hospitalizations with the uptick in cases. I know we talked about that a little bit before, but maybe you can talk in a practical sense about how you guys are managing that possibility.
Yeah, I think it remains a possibility, but I'll be honest, I haven't seen anything on the radar that would hint that that's likely. We have an imperfect vision of the future, but we do have a pretty good vision of the next month or two based on what we see coming forward. And there's not been any sort of emergence of subvariants or emergence of vaccine evasion that puts us at concern right now. Not to say the increase in cases isn't a concern in and of itself, but I don't think it has the potential to cause waves of people coming to the hospital like we saw with Omicron. It's different in terms of, to get to the morale question a little bit, it's very different depending on where we've been over the last 12 months. It was almost more challenging in sort of July and August when the majority of people were still really being very cautious. Most vaccinated people were not getting sick, or if they were well. And the people in the hospital were almost universally unvaccinated. That was, if anything, a little more beleaguering, frankly, for staff. Whereas I think in January, there was just, everyone was getting sick, quite frankly. And, even at a hospital of our size, we had more than 1,000 people sick on any given day. There's a certain recognition that even people who really tried hard to do the right thing at that time were still getting sick, and family members were involved. And it was kind of an all hands on deck approach, which honestly actually led to a little more, I think, better morale is not the right word because it was clearly hard, but it was a different feeling. I think now those protocols are very set in place. Everyone fortunately here has been vaccinated. That's been our policy for a long time. And I think that's held us in really good stead because we haven't had a hospitalization of one of our own employees now for months. And that helps morale because, there's nothing like seeing some of your own colleagues get sick. whereas we've not seen that significant level of employee illness in quite some time. That's been really pleasing.
Absolutely. Thank you both for that comprehensive overview. Dr. Wolf, we'll stay with you. And this is a tricky one, but we'll throw it out there. We know that there's an undercount of cases right now because people are testing at home and a lot of people are asymptomatic and never know they've got it. Do we have any kind of best estimate for how many cases that we're missing in the community right now? And is it important that we do know that?
You're correct that we underestimate. And I think it's at best projections as to how much we underestimate by. We look at those estimates in a number of different ways, so we can sort of feel parts of that large elephant. So we can look at it through wastewater testing and get a sense of the quite steep increase in COVID in effluent amounts. We get a sense of it by the number of absenteeisms from work are actually one of the best tracking mechanisms. So, for example, we have a set healthcare workforce of approximately 23,000 individuals, and they report to us when they get sick and need to take time off from COVID. And so that number has, increased by 7-fold in the last month. And so that's a direct measure of how much COVID is in the community, because they're not getting it at work for the most part. They're just generally community acquired cases. That's a pretty hard and fast number. But at the end of the day, the actual number probably matters a tiny bit less. It's important that we have these discussions that cases are going back up and that people be careful. But as you see, for example, from the CDC county by county indicator, simply the number of cases is a little less relevant than the blending of numbers of cases with impact. And impact is what we've been talking about with hospitalization rates and proportions of beds that we can fill with COVID patients and we can't fill with other patients. And like you've been hearing here, there's been this progressive divergence over the last 12 months between case burden and case impact. And so, does it matter if I know the exact number? Actually, probably less. We don't track the exact numbers of flu cases each year, for example, and yet we know the impact of them. So it is important, I think, for folks to recognize that it's not the overall numbers of tests that we look at that we see as positive that's not the entirety of the cases. It's probably less than half of the cases, far less. But that impact is becoming less, and that's crucial.
Sure, thank you. And you brought up the wastewater numbers because that's one way that we can get a preview of kind of what's coming. Would you expect that one of the earliest ways that we'll know that maybe this current wave is over is that we'll see a drop in those wastewater numbers? Would they be something for people to look at if you want a sense of where cases are likely to go over the next few weeks?
Yeah, I think nationally it's quite a helpful indicator because there are now enough wastewater testing sites that we can get a pretty good indication. It depends on where you want to look. I'll be looking at our employee rates. That's a very local, close to home hit rate for us that is absolutely relevant to the surrounding Tri-County area. But sort of if you want a national view of the way things are moving, I think that wastewater assessment is good. It still lags a little bit. In the same way that we had to have a week to 2 week lag in sequencing testing, you get a lag in the wastewater detection. Someone's got to be sick before you'll find it in their sewage, literally. And that takes time to collate that. It takes time to assess that, synthesize that data. You're probably looking at what happened a couple of weeks ago, but it's as accurate as occurs on a national front at the moment.
Sure, absolutely. Thank you. Dr. Ross, coming back to you, again, you mentioned earlier about how it's been a long 2.5 years. We've talked about hospital morale. We had a question come in where even though cases are higher right now, it doesn't feel like there's maybe the same urgency in America in general to kind of bring this down. Are you kind of concerned that maybe people are fatigued and not taking it as seriously now? Or the fact that, the vaccines are doing their job, do you think that's doing, enough to contain this? Or do you think people should be doing more on an individual level and showing a bit more urgency than they are right now?
I think I think we need to be compassionate. It has been a long 2.5 years for everyone involved, including us as healthcare workers. And so I think it's okay that people are tired. I just think that we can't forget the basics of what we know and realize that we're still in this and that for certain populations within our community, they're still very vulnerable. And so I think we just need to be mindful on as we, maybe it's in a different way that we show up for our neighbors that we did before. But I think, people are tired and they want to go out and they want to do things, which I think are all normal. impulses that we think they're healthy things to do. I just think where we are is we just want to make sure that people are still thinking about those that are most vulnerable. And I think we are at a point where similar to the flu, if I have the flu, I'm not going to go out and, and just do a whole bunch of activities without thinking about others. And I think this is the same thing. And so I think people probably are a little fatigued. I think we're all tired, but for us, it's still something that we have to manage. And it's important that community not forget about us as healthcare workers, as far as all the things that we want to be there for you guys. And so thinking about how we can continue to partner together. And again, going back to, if it's in a high rate of transmission, thinking about whether it makes sense for you to wear a mask indoors, especially if you're around members that are not living in your household, thinking about, as Cam said, your choices right before you go on a trip, and flying, and those things will help us all keep the levels low and prevent other subvariants that might eventually escape our vaccines effectiveness. So I think it's just, we want to acknowledge where people are and hope that they'll continue to partner with us. And we have to all be flexible, right? We're trying to, the things that we knew in the beginning are different than the things that we know now. And I think it's important for us to be flexible as healthcare workers, and also the community to be flexible as we try to figure out the best way to keep each other healthy.
Sure, absolutely. Thank you. And you mentioned, subvariants. Dr. Wolf, you talked about this earlier. We've had a couple more questions about this. You mentioned how we've got subvariants of subvariants. The differences are very subtle. And one question is asked is, does this, the subtlety between variants, does this complicate the efforts to make a targeted booster or make a pan-coronavirus vaccine? The more of these variants that come out, does that just make that whole situation less likely and more complicated?
It certainly makes it a challenge, that's for sure. I mean, if you had a perfect non-variable virus, this would have been quite a lot easier. I think the message there is tricky because it depends on what the variant does. If it's just little subtle variations, for example, with subtle variations within Omicron that we're seeing at the moment, the expectation is that many targeted Omicron vaccines, in fact, have quite a broad array of activity. We've seen that already. So the vaccines that we developed against the original Wuhan and early variant strains that we still use are still active against Omicron. They may just have lost some of their impact. So an Omicron specific variant, even if it doesn't precisely target sort of, BA version 2.1 point whatever comes next, gives you broad neutralizing activity, generally better than what we had in the previous episodes. And look, this is exactly what happens with flu. I think people shouldn't forget that, there is this effort each year to sort of look and see what variants are currently circulating, predict what's going to be here at a time when 6 months down the road, we're having to start getting flu shots into people's arms and to start manufacturing accordingly. And I think that process is what is going to keep occurring here. Does that leave a slight opportunity for a variant to occur that truly escapes vaccine targeting, or that we end up with a misprediction of what's going to be circulating in 6 months' time and make a vaccine that doesn't quite work by then? I think that remains a possibility, but that's been a far more remote risk than the sort of scary story might tell you. So I think the right step is to certainly try and make variant targeting boosters, because they will be more neutralizing and more helpful. Will they be precise? No. Would it be great to control variant development by controlling spread better to guarantee a better mix? Yes. But we've not proven very effective at doing that over the last 2 years. So we've got to accept that it's going to be a little bit imperfect.
Sure, absolutely.
It's a long answer to your question. Sorry.
Yeah, no, that's fine. We've had another very specific question about variants that you kind of addressed a little earlier, but I'll ask it since it's there. Is someone who contracted the BA1 variant this past winter protected against the BA2 variant? Do we know anything about that?
So they will have partial protection only. We know that there is cross-reactivity between antibodies for BA1 and BA2. We know that if you had BA1, you're less likely to get as severe an episode if you come down with an Omicron that's currently circulating, which will be largely BA2 or beyond. They don't perfectly match. So that sort of really comes down to the original question I think that you asked, is can you get reinfected? And the answer is yes. Can you get reinfected in a way that leads to the sort of widespread inflammatory arrangements that we saw in 2020 and 2021, that seems highly unlikely. Again, the exception to the rule are the transplanted or chemotherapy patients who don't remember the last time that they were vaccinated or had COVID. And so for them, this continues to be an issue. And for those patients, increasing community transmission is an increasing direct risk. But for the rest of us, there's some cross memory, but it's imperfect.
Sure, absolutely. Thank you. Thank you, everyone, for the questions. You've got one more chance to post them in the Q&A window. We're going to be wrapping up here in just a couple of minutes. Before we do, had a number of questions about testing. And Dr. Wolf, we'll stay with you, and Dr. Ross, I'd like to get your thoughts on this too. How important is testing right now? We know people are testing at home and hopefully isolating when they're tested positive, but we're seeing how some airlines are pushing to remove testing requirements for vaccinated travelers, for example. If that were to happen, do you think there are consequences there? Do you think that's a common sense move? What are some of the issues involved in that?
Yeah, I mean, I think generally speaking, we're in a much better situation with testing, aren't we? Let's start there. Like, this is far easier for us to know who's sick and manage who's sick and self-manage if you get sick than where we were a year ago. So that's clear. You know, anyone who's listening to this who has not gone onto the federal website to order more COVID tests that will be delivered to your home should go and do that. It's free, it's easy, they're available, you should do it. That said, you know, what are the caveats? Number one, there are some false negatives when you do a rapid test. You know, they're not quite as accurate as the PCR, although you get an instant response. So if you're symptomatic and you get a negative, be prepared to repeat it 12 to 24 hours down the road. That's standard talk we've learned. You know, you can do actionable things with a test result though. So when it comes to airline travel, which is to the sort of greater part of your question there, you know, I think there's incentives for airlines to want to take those sorts of guidelines away, want to take those rules away. That, you know, it's got to be incredibly complicated for people to have to make last minute changes to their flight patterns and airlines to accommodate accordingly. I mean, that's globally a logistic incredible challenge. And it is true that the reasons those tests ahead of, say, returning to the US international flights were put in place were to try and minimize the importation of new variants from other countries. You know, we really did that at around the time when Omicron first emerged in South Africa. And that is largely an ineffective strategy. Let's be really clear on what that has done. There have been very few impactful sort of testing methods that have stopped COVID moving liberally through many different countries. So if you're not using it for that, what are you using it for? You're really using it for the fact that, particularly with international or long haul travel, I'm going to be sitting next to this person beside me for many, many hours. And so the implications of taking those required tests away are that the responsibility falls on that individual person to make really careful and thoughtful decisions for the people whom they're traveling with. And, you know, there will be probably people who don't recognize their symptoms or don't think to get a test or can't find a test at the last minute if they feel symptomatic, get on that plane and they're actually infectious. That probably happens today. So there are health implications in taking those rules away. There's clearly logistic advantages in doing so from the airline's point of view. But if they were to go away, I think people need to be very responsible to the folks who they're sitting with. Like, if I'm going to fly back to, you know, internationally for 6 to 8 hours and I've got some symptoms, I don't want to sit next to the poor person beside me who's going to be exposed to me for that long. And that's, I think, my responsibility with the freedom of getting back to travel. I think that comes with some personal responsibility. Sorry to get a bit passionate on that one. That's important to me.
No, I think you did a really good job. I was just thinking the same thing. And I think, you know, testing isn't perfect. And that's why if you've been exposed, right, and you're within that window, you need to serially test. And I would definitely say, if you've been an exposure, you got your vacation, you tested negative, that's great. But I would still consider wearing a mask as following the CDC guidelines during that time period. And so I think those are those kind of decisions to make sure that if you're traveling and you make that choice and you're willing to potentially risk being stuck somewhere, which is an individual decision, that you're not infecting other people that may be at high risk that are sitting next to you. So I think testing isn't perfect, but I think Dr. Wolf kind of illustrated its importance. And I think because it's not perfect, if you've got to really think about, what have I been exposed to? and make a choice to protect the community if there's a possibility that you could be asymptomatically spreading it, or you could have minimal symptoms.
Absolutely. Thanks to you both. We're about to wrap up here. I've got one more question I'll ask you both. And we've talked today about obviously having colds and the flu. Based on the kind of 2.5 years of data that we have, and we'll start with you, Dr. Ross, is your expectation that, say, in 2 or 3 years down the road, when somebody develops symptoms, that it's just going to be part of the fabric, that it may be the cold, it may be the flu, and it may be COVID? Should we just expect that those at-home COVID tests are going to be in our cabinets for years, and it's just something that we're going to kind of live with and manage, hopefully in a way that we've been seeing with much less hospitalizations and severe illness? Do you think this is just essentially kind of a part of a way of life for right now, or based on the last 2 years of data, do you think that there is any chance of eradication of this thing?
You know, it's a good question. I mean, I wonder, you know, and I'd love to hear what Cam has to say about this, but I think we're moving into a different phase. I think one of the blessings that came out of this was just the infrastructure that was put in place to allow people to have rapid access to testing, which I think is something we hope that in the future there will be other platforms, flu and others, things that are widespread. You know, it's interesting when you think about testing, when you're starting talking about this question, I was also thinking about masking and how is it going to be normal etiquette that if I have a cold, or I'm ill, that regardless of what variant, regardless of if we eradicate COVID and the flu isn't that bad, you know, should we as good citizens just wear masks? And I'm hoping that that's where we'll go, you know, and thinking about also in the winter, you know, am I going to be more likely just to be wearing a mask all the time going forward? And those are some of the questions I think among my friends and colleagues we talk about. But yeah, I you know, would love to be at a place where we are not, this is not on top of mind, and we're looking at this more as the common cold kind of situation, but it's hard to predict where we're going to be at. But I think if we continue with our principles that we have, continue if we're ill, just to be, you know, very courteous and wear a mask and, you know, get tested for those things that you can get tested for, whether it's COVID or the flu, we'll continue to make sure that we have less disruptions in our lives.
Absolutely. Thank you. Dr. Wolf, any closing thoughts on what the longer term future might hold? I know you love these crystal ball type questions.
I mean, I actually loved Adia's answer. I mean, I share the same hope that we reach a level of sort of community awareness that the idea of putting on a mask if I feel symptomatic in any way is much more standard. Like, there are plenty of parts of the world where that's the case already. And you know, that seems to be a really community-minded way of coming out of this. I don't share any optimism that COVID's going to go away. It's going to be here. That's been clear to me, I think, for quite some time. But its impact will get less. It has already. And then I think you're left with a good situation to say, look, you know, the impact of many respiratory viruses is significant for people who are at risk, be they elderly, immune suppressed, or chronically unwell, or super young. Let's not forget young kids in this equation. And that maybe I can make an individual decision based around the people around me and based around my concerns and risks. And if that involves wearing a mask, that's not that hard. God, we've been doing it for 2 years. It's pretty easy.
Absolutely. Thank you both. I think that's a perfect place to call it. Thank you, everyone, for joining us. Thank you to our panelists, Dr. Adia Ross and Dr. Cameron Wolf, for sharing your perspectives. If you'd like to be notified of upcoming briefings, please email dukenews@duke.edu. In the meantime, please stay well, wear a mask when it makes sense, and just think about your community. Thank you very much for joining us, and have a great day.
Thanks so much, Craig. Thanks, Adia.
Thanks.